Okay, so we will continue with infections, and today we will cover fungal infections and fungal-like organisms. So in terms of fungal infections, these are some of the organisms that you should be familiar with. And we can think about these fungal infections as basically two types of fungi. There are the primary pathogens, and these are dimorphic fungi. They have mycelial and yeast forms within the soil. They form mold, so they will have hyphae and spores within the soil, but at body temperature, when they affect humans, they take on the yeast form, hence they are dimorphic. And so these are the primary pathogens to be familiar with. As opposed to opportunistic organisms, fungal organisms, these are not dimorphic, and these tend to affect immunosuppressed hosts. So if we have a case like this, where we have these nodular opacities with ground glass halos, and then we see this one is developing an air crescent, well, of course, we're familiar with invasive aspergillosis. So invasive aspergillosis will give you nodules and masses with ground glass halos. This tends to affect neutropenic patients, and we may see the air crescent sign here when cavitation occurs in the periphery of these lesions. Airway invasive aspergillosis can also occur. This usually affects patients with AIDS. They don't have to be neutropenic. The fungus invades the airway, and you can get these tree and bud opacities or these central lobular opacities affecting the airways. So it can behave like a bronchopneumonia with bronchogenic dissemination. We also have semi-invasive aspergillosis, so this also can give you a chronic consolidation and it can develop into cavitation, but this is a chronic smoldering infection that goes on for many, many months. Here's an example here actually that proceeded for years. So we can see the chest radiograph here and the chest radiograph and CT 6 years later. So you can see that this can resemble tuberculosis, but the infection tends to be quite prolonged and might give you upper lung fibrosis, as in this case with architectural distortion, bronchiectasis, and even cavitation. And then we're also familiar with this with the fungus balls. So these are mycetomas that can form from aspergillosis within pre-existing cavities, and you can see when you shift the patient's position, the fungus ball falls to the dependent portion of the cavity. So these are the different forms of infection that we can get with aspergillosis. Another type here, we have bronchiectasis, and if I tell you that this patient has asthma, so here you would be thinking about allergic pulmonary aspergillosis, allergic bronchopulmonary aspergillosis. So when it comes to aspergillosis, we can think of the form of infection being related to the immune status of the patient. So severely impaired immunity patients who are neutropenic can get the invasive form of aspergillosis. Patients with AIDS can get airway invasive aspergillosis. Patients with chronic lung disease, especially COPD, can get semi-invasive aspergillosis. Normal patients can develop fungus balls if they have pre-existing cavities in which the balls can form. And then you can think of asthma being a hyperimmune state, and that can be associated with allergic bronchopulmonary aspergillosis. All right, so let's move on now to the primary pathogens. And if I tell you that the endemic areas for this particular pathogen, this particular fungus, is central and eastern United States, Mississippi, Ohio, and St. Lawrence River valleys, you should be thinking about histoplasmosis. So the fungus is found in the droppings of birds and bats. There's an epidemic form of infection that can occur with heavy exposure during construction or demolition, especially for chicken coops and in old houses where the patients can inhale a large amount of the organisms, and then that can give you diffuse very severe lung disease. So many of these fungi can affect normal hosts and also immunocompromised hosts. So for aspergillosis, for histoplasmosis in a normal host, you can have asymptomatic infection, you can have foci of pneumonia. In the acute inhalational form, the epidemic form, you can have diffuse lung disease with multifocal sites of infection. The opportunistic form can give you chronic cavitary histoplasmosis. This usually occurs in patients with underlying lung disease like COPD. And then, as in all of these fungal infections, patients who are immunodeficient can develop miliary disease and disseminated disease not only to the lung but throughout the body. Most patients can have asymptomatic infection. They might have patchy pneumonia. This can be associated with adenopathy, as in this case, you see right paratracheal, right hilar adenopathy. So fungal infections can cause lymphadenopathy. And histoplasmosis infection can result in a histoplasmoma. So these can be these nodules that form, and they might have this characteristic appearance of this peripheral ring-like calcification. So you may see that in a histoplasmoma. Here's another example of a histoplasmoma. This one has central calcification, not the more classic ring-like calcification. You can also have pneumonia with histoplasmosis infection, especially if there's a large inoculum. So these patients can have brief, mild malaise the symptoms can vary from a brief mild disease to a protracted flu-like illness. And again, it may show the chest radiograph and imaging, we may see consolidations and we may see lymphadenopathy. As in this particular example, we have some right perihilar consolidation and right hilar lymphadenopathy is another example with some right upper lobe consolidation here and right paratracheal lymphadenopathy. Here's the CT scan on that case showing some right hilar lymphadenopathy and this right upper lobe consolidation from pneumonia secondary to histoplasmosis. Now, if there's heavy exposure with a large inoculum, you can get multifocal sites of infection like this, forming kind of these nodular opacities throughout the lungs. The symptoms can be severe. Patients can develop multiple nodules, and when they heal, they might heal with calcifications. So here's an example of multifocal kind of almost hazy, nodular, ill-defined opacities. And here's a CT showing you those kind of ill-defined nodular opacities here throughout the lung. This patient also had some lymphadenopathy. You can see bilateral hilar and some subcarinal lymphadenopathy in this case. And then when it heals, it might heal with calcifications. So we might see these multiple calcifications here throughout the lung. In an earlier talk, we discussed the differential diagnosis for calcified lesions that might occur throughout the lungs. Now, what might be highly suggestive of histoplasmosis is pulmonary calcifications greater than 4 millimeters in diameter or lymph node calcification greater than 10 millimeters in diameter, combined with greater than 5 calcifications in the spleen. So histoplasmosis can also give you granulomas, calcified granulomas within the spleen. Now, chronic histoplasmosis can occur as a complication of emphysema, so the bullae can be colonized by the fungus, and this can go on to form infected cavities. And usually this affects the upper lobes. The infected fluid may spill into the bronchial tree and then into adjacent lung, resulting in pneumonitis and lung necrosis. So this also might resemble tuberculosis with this upper lobe disease that might look cavitary, although here we have the fungus causing infections within these bullous changes here within the upper lungs. Patients might also develop air fluid levels here as a result of the infection, and progressing fibrosis can also occur. And so here's a diagram showing you these areas of emphysema here, and then when the patient develops consolidation, these areas of emphysema can look like cavities, although they are not necessarily cavities. Now here's chronic histoplasmosis again. We have these upper lobe, looks like fibrotic disease with parenchymal opacities and these cavitary or cystic changes, and 2 months later you can see that there's been progression of the fibrosis. So this also can resemble tuberculosis. Another example of chronic cavitary histoplasmosis, and then after treatment you can see that There's less apical pleural thickening and less in the way of opacities, but we still have this background cystic change there within the upper lungs, again resembling tuberculosis. And then here's a CT scan showing you architectural distortion and cavitary change here within the upper lungs, again resembling tuberculosis. Disseminated histoplasmosis can occur in immunosuppressed patients for some of the reasons that are listed here. So the organism might disseminate throughout the body and not just to the lungs. So patients may develop hepatosplenomegaly, lymphadenopathy, and CNS symptoms. So here's an example of bronchogenic dissemination, where we have these central lobular opacities as the organism has disseminated throughout the lungs bronchogenically. Here is hematogenous dissemination giving you miliary disease. You see this random distribution of small nodules, a micronodular pattern here. This patient was HIV positive. And another example of miliary disease from disseminated histoplasmosis. Now, we did cover in a prior lecture the differential diagnosis for random distribution of nodules. Suffice it to say that it usually implies hematogenous dissemination, so we would think about infections such as miliary TB, miliary fungal infections, and also we might consider metastatic disease. That can also give you a random distribution of small nodules. Now, there are a whole host of complications that might occur from histoplasmosis. Here's a nice example here where we're looking at the chest x-ray, and we have volume loss here in the right lung, a little bit of fullness here in the right hilum. The perfusion scan shows a complete lack of perfusion here to the right lung, even though there is ventilation to the right lung. So something is obstructing the blood flow here to the right lung. Well, what complication of histoplasmosis is this? Well, this is what we see with fibrosing mediastinitis. With fibrosing mediastinitis, infections of the lymph nodes can cause fibrosis within the mediastinum, and then that might encase pulmonary vessels. Here it's obstructing the flow through the pulmonary artery, leading to the perfusion abnormality. We also see interlobular septal thickening here as a result of obstruction of the pulmonary vein and asymmetric pulmonary edema. So these are changes we might see with fibrosing mediastinitis. So histoplasmosis is the most common infectious cause of fibrosing mediastinitis. Tuberculosis can also do it, but it's more common. Histoplasmosis is a more common etiology. Another example, and one might be suggestive of histoplasmosis or an infectious etiology, is if we have calcifications here within these enlarged lymph nodes within the mediastinum. These calcified nodes, you can see the right paratracheal lymphadenopathy here, and calcification of these nodes along with this fibrotic process in the mediastinum suggests that it may be post-infectious, either from histoplasmosis or tuberculosis. Now, here's another complication that can occur from histoplasmosis. Here we have right upper lobe atelectasis, but we have this calcification here overlying the right hilum. So what is happening here, these are calcified nodes, and this one has eroded into the airway, producing obstruction, and then that can go on to form atelectasis. So this is broncholiithiasis. So calcified lymph nodes from histoplasmosis can erode into the airway and cause obstruction. That can also occur with tuberculosis, so we call this broncholiithiasis. We've already covered this. What do we call this lesion that has this ring-like peripheral calcification from histoplasmosis? We call this a histoplasmoma, and this might grow over time. Sometimes it can develop these shells of fibrosis, fibrotic reaction here peripherally, and you might get concentric calcification like that in the periphery of the lesion. All histoplasmomas don't have to calcify. Here's an example of a nodule here from histoplasmosis forming histoplasmoma, and this one is not calcified. So here we have this low attenuation here within the lymph nodes in the mediastinum from histoplasmosis. So these are mediastinal granulomas, and you can see that's very low attenuation here, and then on the follow-up study we could see that it's developed some calcification, and it's healed a little bit as that low attenuation necrosis has resolved here in the center of the node. And then here we see it in the mediastinum, causing mass effect here on the esophagus. So lymphadenopathy can also occur from histoplasmosis. So these are complications that might occur from histoplasmosis that we should be familiar with. So here's our next case, a 65-year-old man. We see we have a PICC line here. We see we have these ill-defined kind of nodular or mass-like opacities. And when we look on CT, you can see these low attenuation nodules or mass-like opacities here scattered throughout the lungs. They are bilateral, although they seem to be more prevalent on the left side. Then when we look closely at the rest of the imaging here, we can see that this patient also has some brain lesions. There are brain lesions here. And we note that the patient also has had a liver transplant, and there are some lesions here also within the spleen. So certainly neoplastic disease would be on your differential, but this patient will be immunosuppressed as a result of the transplant. So we do have to consider infections that might affect the immunosuppressed host, and this was Cryptococcus. So Cryptococcus is worldwide. The fungus can be inhaled and deposited in the subpleural regions of the lung, and that's where it might form infection. If cell-mediated immunity is intact, that can heal, but if it is not, you can have chronic pulmonary infection and hematogenous dissemination. So meningitis, meningoencephalitis are the most common serious consequences of extrathoracic spread. There's another form of cryptococcosis, Cryptococcus gatti, and this is found in the Pacific Northwest. Cryptococcus neoformans can be worldwide. So in normal hosts, we might have nodules or masses, we might have consolidations, and as with all fungal infections, you can have disseminated disease, you can have miliary disease. So nodules or masses are very common. That's the most common finding with cryptococcosis. So here we see these nodular opacities. More examples of nodular opacities from cryptococcosis. So again, it might simulate metastatic disease. This one has developed some cavitation, so we can also see cavitation within these lesions. In immunocompromised patients, in AIDS patients, this is the most common fungal infection, excluding pneumocystis. Patients with hematologic malignancies, organ transplant, as in our liver transplant patient, and steroid therapy, all of these patients are at increased risk for cryptococcosis. So in these patients, there's a greater tendency for cavitation, adenopathy, effusions, and disseminated disease. CNS involvement, meningitis, that is the most common extrathoracic site of involvement. So in immunocompromised patients, again, we can have nodules, although here there is an increased propensity towards cavitation. You can have consolidations, lymphadenopathy, or miliary disease. So here's an example where we have cryptococcosis here presenting as a nodule or mass-like lesion there in the left lung. And then as with all cases, all of these miliary infections kind of look the same, this diffuse micronodular pattern, and in this case it was cryptococcosis in a patient with AIDS. So all patients, tuberculosis is not the only cause of miliary infection, especially in AIDS patients. So in addition to tuberculosis, we might also consider fungal infections like cryptococcosis in patients who have AIDS. So for our next fungus, the endemic areas are desert climates, so semi-arid climates, San Joaquin Valley, southwestern United States. So earthquakes, dust clouds, high winds, this can release the fungus from the dirt and then can from the ground and then cause infections in the population. This fungus, of course, is Coccidioides, resulting in Coccidioidomycosis. So the endemic areas are these desert climates, as we've said. So we can have asymptomatic infection, and that might heal with calcification or granuloma formation. And symptomatic infection, this can give you primary disease or chronic disease, and as with all fungal infections, you can also have miliary disease. So with primary disease, the symptoms resemble a mild viral infection. This has also been called valley fever. These patients might have erythema nodosum, erythema multiforme, and arthritis. On imaging, they might have consolidation, streaky densities, nodular or patchy opacity. Some might have lymphadenopathy, and some might develop pleural effusions. So consolidations and plus or minus lymphadenopathy can occur with this fungal infection, as with many of these fungal infections. And again, we might get nodules, again, like we might with any of these other fungal infections. And then here we have nodular opacity here with pleural effusion in this example. And lymphadenopathy might also occur. Here's right hilar lymphadenopathy, right hilar and subcarinal lymphadenopathy, and this can occur with any of the fungal infections. Now, this organism might also give you chronic infection where you might develop nodules or coccidiomas, these kind of nodular-like lesions that can occur within the chest. Here's an example. So this non-specific nodule on biopsy turned out to be a coccidioidoma. We can have cavitary lesions here with this infection, and what might be characteristic is a very thin-walled cavity, although that's seen in only 10 to 15% of cases, and then some patients might also develop persistent pneumonias. So here's an example where we have a lesion with cavitation, and then here it is on the CT. We can see that cavitary lesion there. And then here it's rather thin-walled cavitary lesion here. And here's a nodule in this particular case. And then here you can see the sequela develops this nodular or mass-like lesion, forms cavitation, gets smaller, and then you're left with this thin-walled cavitary lesion. So this can be a very typical appearing sequela of this particular infection. So this thin-walled lesion is the classic lesion here, although, as we've said, it doesn't occur in a large percentage of the patients. Patients can have lymphadenopathy, chronic progressive disease that can resemble tuberculosis, pleural effusions, and then some might develop regressive end-stage fibrotic disease. So here's a patient with lupus who has these cavitary lesions here in the upper lungs. You can see that bronchiectasis, traction bronchiectasis here with fibrotic changes. Again, this can resemble tuberculosis. So fungal infections is something else to consider in your differential for somebody whose imaging looks like cavitary tuberculosis. And then disseminated infection can occur in patients with malignancies or in patients who are immunosuppressed, especially pregnancy. This can be associated with pregnancy. We can get disseminated disease, and that looks like miliary disease as we've seen before, these multiple micronodular pattern here in a random distribution scattered throughout the lungs. So our next fungus here, the endemic area is south central, southeastern, Midwest United States, Ohio and Mississippi River valleys here. So we're talking about blastomycosis for this particular infection. So this fungus is found in moist soil and in wooded areas. So what can be characteristic here is that the fungus can disseminate to extrathoracic sites. So the skin is the most common, but it might also involve the bone. Subcutaneous abscesses that grow to become skin ulcerations can be a common manifestation. So these patients can develop consolidations, masses in the lung that might resemble lung cancer, and they might also develop miliary dissemination of disease. So here's an example. This patient has this large consolidation here, and this was from blastomycosis. Here it looks like a mass, so it can mimic lung cancer, another example of blastomycosis. This patient has a cavitary lesion here, again in the left upper lobe. And as we've said, what can be unusual about blastomycosis is it can involve the bone. So you can get dissemination to bone and osteomyelitis. Here you can see it involving the tibia along with the rib in this particular patient. Another example where we have a lesion here in the lung that looks like cancer, an olytic bone lesion. Of course, you're thinking about lung cancer with metastatic disease to the bone, but this was blastomycosis with osteomyelitis here involving the tibia. Here's a patient who had ulcerating skin lesion as a result of blastomycosis involving the skin. And then as with all of these fungal infections, you can get disseminated disease with this miliary pattern of dissemination. So it's important to know the distribution of these fungi. If a patient is from an endemic area, then you might be able to add this to your differential diagnosis. Especially when you have cases that resemble tuberculosis, but all the cultures were TB are coming back negative. Now, mucormycosis, this is the bread molds. So these give you opportunistic infection, and so these are ubiquitous fungi found in the environment. And usually it affects patients who have defects in macrophage or neutrophil function, so immunosuppressed patients, patients with hematologic malignancies. This can also affect diabetic patients and patients with chronic renal failure. And the appearance here is like with the other fungal infections. You might get consolidations with cavitation. This can also give you the air crescent sign. Unfortunately, the mortality rate is high when it starts to give you infection like this within the lung, usually because of the patient's immunosuppressed state. So here's a patient who had a renal transplant, and we have cavitary lesions here within the lungs, and this patient has an ring enhancing lesion here in the brain. So again, we have to think of opportunistic organism. This was nocardiosis. So predisposing factors: immunosuppressive therapy, organ transplantation, AIDS or immunodeficiency, alveolar proteinosis. So all of these can predispose to nocardiosis. So this is not a fungus, but a fungus-like organism. It's a filamentous gram-positive weakly acid-fast bacillus. So this can give you consolidations that might cavitate, single or multiple nodules, round pneumonias, and this can disseminate to the brain. So nocardiosis can give you cavitary lesions like this, and this may disseminate to the brain, as in this particular example. This patient was HIV positive and developed this anterior mediastinal mass here, and we see this low attenuation lesion involving the mediastinum actually extending through the chest wall into the subcutaneous tissue, and then there are these additional small cavitary lesions here within the lungs. This was nocardiosis. Now here's our next case, and this patient has this large opacity here in the right upper lobe, and we see here on MR that is actually invading the chest wall, extending through the bone into the subcutaneous soft tissue. So here, if we're dealing with infections, we have to think of infections that might involve the lung and the chest wall. We've seen nocardiosis is an infection that can do that. Certainly tuberculosis can also do that. And then here on the CT scan, we can see this right upper lobe consolidation and actually extending through the chest wall, involving the bone, extending to the subcutaneous tissue. So probably the first organism to think about that can do something like this is actinomycosis. So actinomycosis is an organism that is found in the oropharynx and can infect devitalized tissue. It can infect the lung if it's aspirated. So this organism produces proteolytic enzymes, and that allows the infection to cross fascial planes, resulting in pneumonia, empyema, abscesses, sinus tracts, and bone destruction. So this infection can extend into the chest wall from the lung parenchyma, and sulfur granules here are a characteristic finding on pathology. So it's common to get masses with cavitation with this particular infection. So here we have another example of cavitary lesion there in the right upper lobe. But this can extend through the chest wall, can involve the bone, as in these examples here. So actinomycosis can give you bone destruction, osteomyelitis, and can involve the soft tissues of the chest wall. Here's another example where we have this opacity here in the left mid lung, and it turns out to be actinomycosis here involving the lung parenchyma extending through the bone and chest wall into the subcutaneous tissues. So a lot of these infections that we've discussed might have nonspecific appearances. So the question is, what is important to remember here? So let's go over that. So for histoplasmosis, asymptomatic infection is the most common. With acute infections, if there's a small inoculum, patients might have pneumonia plus or minus lymphadenopathy. With a large inoculum, patients tend to develop nodular opacities, which may go on to calcify. Chronic infection, that tends to affect patients with COPD, and disseminated infection will give you a miliary pattern of disease. The complications to be familiar with: histoplasmoma, fibrosing mediastinitis, bronchiolithiasis, and mediastinal granuloma. Cryptococcosis can infect patients with AIDS. It tends to give you pulmonary infection, but it can also give you meningitis. So this organism can spread to the meninges. Coccidioidomycosis, the classic lesion here is that thin-walled cavitary lesion within the lungs, although as you said, this occurs in about 15% of cases. Blastomycosis can mimic lung cancer, but the thing to remember here is that it can disseminate to bone and give you osteomyelitis. Mucormycosis, this affects immunocompromised patients and resembles invasive aspergillosis, gives you cavitary lesions, might give you the air crescent sign. Nocardiosis affects immunocompromised patients. This can disseminate to the brain. And actinomycosis, this can affect immunocompetent patients, but the important thing to remember is that this is lung parenchymal infection that can spread to the chest wall. So if I tell you that this is a fungal infection, so here we have a patient with a cavitary lesion here and a bone lesion, well, you should think of blastomycosis. Here's a mass-like opacity here within the lung, and if I tell you it's a fungal infection, well, blastomycosis again is the one that can resemble lung cancer. The thin-walled cavitary lesion, coccidioidomycosis, that's what we want to remember there. And then what fungal infection might give you lymphadenopathy like this with calcification? Well, we're thinking about fibrosing mediastinitis here, so here we need to think about histoplasmosis. And then here we have infection in the lung that's also giving us these abscesses, these ring-enhancing lesions in the brain. So in immunosuppressed patients, nocardiosis here is the infection to think about. Transplant patients might develop nocardiosis. Okay, so that concludes our discussion for today. Thank you for your attention, and I will see you next time.